In order to follow up an MDA intervention directed at Plasmodium falciparum malaria elimination, we need to be able to answer two main questions. The first question is about the feasibility of the intervention, whether or not we can achieve a sufficient coverage to expect a good result. And the second one is to follow the community where we did MDA over time to monitor the evolution of malaria and check whether the intervention had the expected impact. We will discuss these two questions using data from a METF, in which we have conducted mass drug administration in about 30 high malaria prevalence villages on the eastern Myanmar. Most of these villages are difficult to access, some are even still in the conflict zone. So the first question really sums up to, can we really do it? In order to assess this feasibility, we need to collect data. We need to collect data about population of the village and data about the participation in the intervention. The population, we get a list from the village headman, and then we confirm it by sending our team door to door in each household. The participation we record every day of intervention by recording participants and drug uptake, and also recording data about the non-participants, the reasons why they are not participating. And at the end of 1 month of intervention, we can look at the proportion of the village population who took MDA. And in general, in a METF, about 80% of the villagers who are present participate. A good participation tells us that our community engagement efforts have been successful. If participation is low, we can look at the reasons why people are not participating. And in majority, these are people who are afraid or reluctant to take drugs while not being sick. So this can help us to target more community engagement. A smaller proportion of non-participants are ineligible people or people who have traveled for a short period. At the end of the 3 months of intervention, we look at the final coverage, which is among all the people reported at least once in the village over the 3 months, how many took 3 rounds, 2 rounds, 1 round, or 0 round of treatment. These numbers are important because the people who take 3 rounds, they are protected for 3 months. So they are removed from the transmission circle for the period of 3 months. So if you remove many people, you can even manage to break the transmission. The people who take 1 round or more, they represent the people whom you clear from the parasite reservoir. If they used to be carrying parasite before, after you treat them, they don't. So if the transmission is, the levels of transmission are low enough, you may still have a good impact with this, with a high coverage of those people. And finally, the proportion of people who don't get treated are the proportion of people who, if they were carrying parasite, they are very likely to still be carrying them. So you want this proportion to be as low as possible. You can see that for METF, we are consistently achieving 1 round participation around 80% or more, and 3 round participation above 60% for half of the village, and above 50% for most of our villages as well. The next question to address is monitor the efficacy of the intervention. So the aim of MDA is to reduce asymptomatic submicroscopic parasite carriage. This means that in order to assess the impact properly, you want to measure the state of the asymptomatic reservoir before and compare it to after the survey, the MDA. So you need to use a very sensitive survey analysis technique, such as qPCR, to make sure that you will count every person, including carrying parasites, including the one who have very small amounts. This follow-up with surveys has been done in 4 pilot villages, where malaria prevalence was followed up every 3 months over 2 years after MDA was conducted. And you can see in this village the impact of MDA on the prevalence, which went down from 20% to 0 at month 3 and remained below 1% over the 21 remaining months of the follow-up. So there was a very strong impact of MDA on the reservoir. You can compare to what happened with Plasmodium vivax, which was about 16 to 17% at the month 0, went down to 1% after month 3, and went back up quickly when the MDA intervention was finished. This is not because there was transmission, but is because of the liver dormant hypnozoites, which are able to cause another bloodstream infection without an infective bite of a mosquito. The problem with those qPCR surveys is that they are difficult to conduct on the field on a large scale, and they are costly to analyze. So in the METF scale-up, we'll only monitor the impact on the reservoir with a survey performed 12 months after the MDA. A second technique to monitor the impact of MDA is to look directly at the transmission by collecting and analyzing the infection of mosquitoes, anopheline vectors collected in the village before and after the MDA. And if you find a reduction or no infected mosquitoes after the MDA, you have good evidence that you have interrupted the transmission. This technique is also quite difficult to set up in a large scale because it requires good skills and good and costly analysis techniques as well. So an indirect way to follow the impact of the intervention is to monitor the incidence of clinical malaria. By definition, asymptomatic reservoir doesn't show as clinical cases. However, where there is no malaria, there will not be any cases. So in a place where the intervention was successful, we expect the number of PF cases to decrease, possibly to 0. In this village, you can see how the high malaria season of 2016, after MDA, consisted in 3 cases. In comparisons, there were almost 20 cases in the same period of 2015. To conclude this presentation, MDA can be performed and monitored via a relatively simple set of procedures: census, community engagement, consent if you are in a study setting, distribution of drugs, recording of participation, and follow-up to address potential adverse events, and then monitor malaria situation in the village. Medics, other health staff, and trained community health workers can be involved in the different tasks according to their abilities. The impact of MDA can be followed over time using prevalence surveys, entomological surveys, and clinical case incidence rate. And it is very important to remember that mass drug administration is doomed to failure if there is no access to malaria diagnosis and treatment in the community. Because, especially in endemic areas, reintroduction is still possible. So it is crucial that any case can be treated very quickly after the MDA has been performed. And the second element, which is absolutely necessary, is the trust of the community. And this is why good community engagement is absolutely necessary before the MDA, during the MDA, and also after the MDA to maintain the good relationship and the good participation of the community in the effort against malaria.